Welcome to the Institute of Medicine of Chicago's virtual series of the 8th convening of the State of Health of Chicago and the 4th session of 2021. This is our 15th session of the series since convening in the fall of 2020. Our focus is to create collaborative opportunities for systemic change in the time of this pandemic through discussions, thought leadership, and building thoughtful, meaningful dialogue with expert speakers and among each other. Over the past few months, due to the pandemic crisis, we all acknowledge that more work is needed, which is why we challenged ourselves with the theme, We Can Do Better, this year in the State of the Health of Chicago program. I'm Cheryl Rucker-Whitaker, and I'm the president and chair of the IOMC, and it's my pleasure to welcome you today to today's program, The Path Forward for Nursing Home Residents, Lessons Learned from the Pandemic. I want to thank the Institute of Medicine of Chicago Board of Governors for their leadership and support this year, and with their ongoing efforts with attaining support and funding for all of these programs. The Institute of Medicine of Chicago, founded in 1915, is an independent organization of distinguished leaders in the field who collaborate to improve the health of the public. We proudly draw upon our diverse membership and other regional leaders to address critical health issues. The IOMC has a long history of advocating for health equity over its 105 years. We've made significant contributions to the practice of medicine, the business of healthcare, and public health. Before we move forward with today's program, I would like to ask that you save the date for our annual meeting that will be held on June 25th of this year. Stay tuned. We'll be sharing more details on our LinkedIn and on our website and in newsletters to you very soon. Today's agenda includes 3 presentations that are led by Pat Merriweather Arges, and our 3 speakers, Dr. Tamara Konecka, Dr. Michael Wasserman, and Ms. Susan Ryan. You will be able to submit questions as we go along and comments using the chat box on your screen. By the end of the session, you will be able to identify the physical and mental impact of COVID-19 on nursing home residents pre-vaccine and post-vaccine. You will recognize the key factors that led to the COVID-19 crisis in nursing homes. You will be able to compare and contrast the impact of COVID-19 on Black and Latinx nursing home residents and staff. And you will be able to explain the short and long-term models to improve quality of life and health outcomes for seniors that need nursing home care. This program is accredited by Rush University and affiliated associations. You will be able to obtain your continuing education credit by completing the online survey after the program. All speakers met the disclosure requirements for this program. We wish to thank our State of the Health of Chicago sponsors for the generous support of the entire series. We thank Blue Cross Blue Shield of Illinois, Northwestern Medicine, Rosalind Franklin University, the University of Chicago Medicine, the Portis Foundation, Michael Reese Research and Education Foundation, the Washington Square Health Foundation, Hectone Institute, Complete Care, Aunt Martha's Health and Wellness, Care Advisors, and Golden Square. And now to introduce our moderator and convener for this session, Ms. Pat Merriweather Arges is the Executive Director of Project Patient Care and a Fellow and Board Director of the Institute of Medicine of Chicago. Pat is the co-leader of all Project Patient Care initiatives, including its work in federal healthcare transformation, advocating authentic patient and family engagement across all healthcare settings, and Project Patient Care organizational development activities. Pat, thank you so much. We'll look forward to the discussion you're going to lead today on this very interesting topic. And our fellow Chicagoans and fellow board members are very interested in this topic, so it's very timely. And I'm handing it over to you, Pat. Thank you so much.
Thank you, Cheryl. And thank you, everyone, for being with us today. You're probably wondering, some of you, why we're focused on nursing homes. I hope you've read the news, whether it's social media or in written. there's a great deal of interest in the long-term care services. And in particular, when we've looked at COVID infections, the 85% of them have been in primarily younger populations, younger than 65, and most of them in the 20 to 40 to 50 age group. However, the deaths, 89% of our deaths in Illinois were people that were 65 and older. And when you look at the United States, it mirrors what Illinois has experienced as well. Nursing home deaths have made up about 35 to 40% of all deaths, COVID deaths in the United States. However, for Illinois, it's 48% of all deaths are COVID deaths are nursing home residents. But I also want to point out another interesting statistic that we're not alone, because if you go up to Canada, 70% of all of their deaths have been nursing home residents, or as they call them, care homes. So the importance of nursing homes and trying to get a handle on what's going on with COVID in nursing homes is critical. But we, like everyone else, we've learned from this experience with COVID, and we're continuing to learn. And we know there's another way forward. So today you're going to hear from Dr. Konecka, who is the Lewis Block Professor of Public Health Sciences in the college, with a secondary appointment in the Department of Medicine, the section of Geriatrics and Palliative Medicine at the University of Chicago. Not only is she a researcher, she recently gave testimony in front of the Senate Committee on Nursing Homes. Susan Ryan is the Senior Director of the Greenhouse Project. And if you haven't heard about the Greenhouse Project, you need to hear about it, because as she will tell you, and what the data has shown, is they have lower rates of infections and mortality. And it's been written up in just about every nursing home journal and article. And then Michael Wasserman is a geriatrician. He has devoted his career to serving the needs of older adults. And I've worked with Michael Wasserman for the last few months, and I just have to say, he is an influencer on what's going on and the policies in DC. So you have a great group of people. And with that, I'm going to turn it over to Dr. Konecka.
Thank you, Pat. So I'm Tamara Konecka from the University of Chicago, and my role on this panel is to talk about the evidence base, what we know about COVID and the precursors of bad outcomes in nursing homes during the pandemic. People often refer to the circumstances that led to this tragedy as a perfect storm. One part of that perfect storm concerns the attributes of the virus itself. As we all know now, the virus is airborne and can be spread asymptomatically. And especially early in the pandemic, that was really challenging for nursing homes. Combining the attributes of the virus then with the vulnerability of the nursing home made the problem so much worse, because nursing homes generally house sometimes hundreds of residents and often more than one person to a room. And almost by definition, they are there because they need hours of hands-on care every day. And so you can't really physically isolate nursing home residents from the staff who care for them. And there's a lot of good evidence now showing that the main method that the virus by which the virus was transmitted into nursing homes was through staff coming and going every day. So we have this really volatile situation, an airborne virus spread asymptomatically in a congregate setting where people cannot physically isolate. And then combine that with the policy context. And I could say a lot more about that, but basically the situation was exacerbated by the fact that the federal government early in the pandemic failed to secure supply chains for PPE, protective equipment, and testing. And those two, as importantly as they are to the public health control of a pandemic in general, they were even more important in nursing homes. So what we had was this responsibility being delegated to states and nursing homes themselves, which wasn't always very successful in getting nursing homes the supplies that they needed. Next slide, please. So Pat already mentioned some of these statistics, but the result was clearly more than 172,000 COVID deaths in long-term care. Those were numbers as of February. That includes not just nursing homes, but also other long-term care settings. And nationally, more than 30% of the deaths were in nursing homes. And one statistic that I don't hear very often, but I think is really critical to how we think about why this happened, and that is that, at this point, almost 100%, it's literally like 99.9% of nursing homes have had at least one case in their facility. And more than 80%, which is also probably higher by now, have had at least one death. So this is clearly an underlying structural problem and not a bad apples kind of problem. No nursing home seemed to have found the magic bullet. Next slide, please. Finally, after all the devastation of the last year, we see some some opportunity for optimism. And so what we see on this graph is that throughout the pandemic, nursing home deaths, obviously the numbers are at a different scale, but nursing home deaths in their trend have really closely matched nursing home deaths in the community. So basically, communities that were virus hotspots also saw nursing home deaths. And what we see is that in about mid-January, that linking of those two trends finally starts to break. And although we don't have rigorous evidence on it yet due to lack of data, what we see is that clearly nursing home residents and staff were prioritized for vaccination as soon as the vaccination campaign started. And probably this break in trend is due to these vaccination efforts in nursing homes. Next slide, please. We see this also in Illinois. This graph just shows the resident and staff cases and resident and staff deaths in nursing homes in Illinois. And what we see is a downward trend, pretty dramatic trend over the last few months. And now both cases and deaths in nursing homes are at their lowest point since we started tracking them last spring. Next slide, please. Clearly, if you've been noticing in the papers stories about outbreaks in nursing homes despite vaccination, clearly the crisis may not be completely over. We know there's resident and staff turnover. We know that there was low vaccine take-up among staff. We also know that there are new coronavirus variants that may make the vaccines not quite as effective. And so there's still reason to be concerned. And therefore, the evidence that we have found on, the precursors of these outbreaks is still really important. And of course, it's also important so that we can learn lessons for the next time this happens. Next slide, please. So I'm going to go through a few key points about the evidence base. There's now at least 25 published papers. I think a few more have come out before I wrote after I wrote this slide. At least 25 empirical analyses of COVID-19 and nursing homes, mostly focusing on identifying the predictors of cases and deaths. So I'm going to discuss some of the conclusions from this, hitting on three main points. First, the general predictors of nursing home cases and deaths, then looking specifically at race and at the role of staffing. Next slide, please. From this pretty large body of evidence now with some really good rigorous studies, we see two very strong and large in magnitude and consistent predictors of which nursing homes had cases and deaths. Cases, obviously, they all had cases by now, but earlier in the pandemic, we could look at which nursing homes had cases. These two very strong predictors are facility size, with larger facilities being more at risk. Even if you index the cases and deaths to the number of residents, still larger facilities were more at risk, for perhaps obvious reasons about transmission of an airborne virus. The other strong predictor is the prevalence of the virus or prevalence of COVID-19 cases in the surrounding county. And that in magnitude was a very large effect across studies. So having an outbreak in a virus hotspot for two similar nursing homes controlling for other factors meant that you would have 5 more deaths contingent on that outbreak. And there's pretty good evidence showing that, as I mentioned earlier, staff traffic is really the key here, right? So if you're in a neighborhood, if your nursing home is located in a neighborhood where the prevalence of the virus is high and staff go in and out every day, or if staff tend to live in neighborhoods where the prevalence of virus is high, your nursing home is going to be at a much higher risk. Just as important is the evidence showing that basically there's no meaningful relationship between COVID-19 cases and deaths and the baseline level of quality. And this is measured across these studies in as the nursing home compare star ratings overall or by component, but also when we look at very specific things like prior infection control citations. Those were basically not predictive of which nursing homes had problems. It was much more about size and location. Next slide, please. Okay, so I'm turning to race now. And in the interest of time, we won't go through too many of these numbers, but basically what we did in one of our studies that was published back in February in JAMA Network Open was we divided nursing homes based on the racial distribution of the residents. And so here, high facilities is high percent white, right? So to the right is fewer Black and brown residents, and to the left is more. And what you see certainly if you look at the second line there is that residents of color are much more likely to be in really large facilities, right? Where the average number of beds is 127 relative to the whiter facilities where the average number of beds is 88. They tend in general to be, people of color tend to be in lower quality facilities as well. Next slide, please. The data on COVID-19 cases and deaths by this racial distribution of the nursing home is really striking, because what we see here is a very large difference and a very monotonic difference. So the facilities at the top on this graph are those that are the facilities where most of the residents are white, and at the bottom are facilities where there are higher minority populations. And so we see basically this monotonic increase in both the number of cases and the number of deaths from COVID-19 as the percent of residents of color increases. So basically 3 times as many deaths, 3 times as many cases for facilities that are less white. Next slide, please. In that same study, we worked to disentangle why that was happening. And what we found is basically, if you start controlling for different factors, you can tell what accounts for most of the effect. And that's what we were doing here. And so from that top part where we see still huge disparities by the percent white in the facility, once you control for the size of the facility, that disparity decreases about in half. Adding a whole bunch of other factors, like the percent Medicaid in the facility or for-profit status, does almost nothing to reduce that disparity until we get to the bottom where we control for the prevalence of the virus in the community by looking at the number of cases per capita in the county. And there we see another huge decrease. So what do we conclude here? That certainly nursing home residents of color have been much harder hit by the pandemic, but Why is that happening? It's mostly because nursing home residents of color tend to be in those facilities that are at highest risk. They tend to be in much larger facilities that are located in neighborhoods where COVID-19 case rates are high. And it's not so much about other attributes of the nursing home. Next slide, please. Finally, the last piece of evidence I want to discuss is the role of staffing, because looking at the size of the facility and the location doesn't give us much to work with. Like, what can nursing homes do better? Staffing is one of these things. So the nursing home staffing star ratings didn't really do much in studies that looked at that. But if you look at the nuanced sort of detailed levels of staffing, the hours per resident day by different types of staff, we did find a meaningful effect. So facilities that had more total staffing and more nurse aides had fewer deaths contingent on having an outbreak. Having more staff didn't help facilities avoid having an outbreak at all. Again, this is partly about staff traffic, so it could go either way, right? But once there was an outbreak in a facility, having more staff helped. It still was dwarfed. This effect was much smaller than the effect of being in a virus hotspot, but having more staffing is certainly helpful to handling an outbreak. Next slide, please. And this is just a graphical depiction of that. On the left, we have the nurse aide hours per resident day divided into quintiles. And what you see is there's really no relationship. It's flat with the percent of facilities that had cases at the time we did this study. But on the right, you see that facilities with more staffing have fewer deaths. Next slide, please. Okay, so turning to some implications of these three major findings from the literature that I just discussed. One implication is that this really wasn't about infection control procedures. I mean, they're certainly important, and it's important to get those right. But infection control is necessary, but not sufficient. And it really wasn't so much about exactly what nursing homes could have done better. This was a crisis. And as a nation, the single most important thing we could have done, this is what the evidence shows, the single most important thing we could have done would be to control the virus in the surrounding communities, right? To use our public health measures to not let the virus run rampant in the areas around nursing homes, because once that happened, it was really hard to keep it out or to control an outbreak. Another implication is that the evidence doesn't really support sort of performance-based incentives that were implemented by CMS last year, trying to incentivize nursing homes to have better COVID-19 outcomes. What they really needed was probably assistance if they didn't know how to handle an outbreak or didn't have the staff to do so. It's clear that assistance through any of the measures we've been trying to implement really needs to reach large facilities in Black and Brown communities. Those are the facilities that are at highest risk. And obviously there are underlying long-run problems that we need to solve as well, such as underlying chronic understaffing that we've seen for decades in nursing homes. These are really important, big structural problems to solve. Next slide, please. So I'll end with just a note about the American Rescue Plan, which was passed. There were really two main provisions. There were some general provisions that might affect nursing homes, increasing supply chains for vaccines, PPE, and testing. So that will all help, certainly, at least indirectly. There were a couple of provisions directly aimed at nursing homes. $250 million to states for strike teams to really send in assistance when nursing homes need it. To me, that's a really promising development. And then $200 million to quality improvement organizations for infection control and vaccine uptake. So these are also going to be helpful. They won't solve everything, but certainly helpful. And so I'll just end again, I think we're finally moving in the right direction. There's a cause for optimism. obviously we still have some hard problems to solve. Thank you all.
And thank you, Tamara. We're now going to turn it over to Michael Wasserman, who's going to be talking about what's going on with long-term care now and also the future as well. Michael?
Well, thank you. And it's a hard act to follow. I could just listen all day to Dr. Konecka. So go ahead and keep moving forward. Yeah, keep going. We know all this. So I want to focus very briefly on the core elements that will always be needed for battling this virus. And those are abundant PPE. And I have to say, we still have nursing homes in the country that are still struggling to get PPE, and that's just unacceptable. Testing, as we know, needs to be available, especially as we're dealing with variants. As Dr. Konecka said, infection control is a given, but it's not sufficient. And we have promoted the concept and the requirement of a full-time infection preventionist, literally since the beginning of the pandemic. And this is actually something that had been recommended prior to the pandemic. And the one other thing I always like to focus on is the need for excellent leadership in a facility, and that the facility's working in their emergency preparedness pandemic mode. Next slide. The fifth element of what was our quadruple aim that we actually published a year ago is the vaccine. And the vaccine is a game changer. You know, in a lot of ways, it's really a shame that as the pharmaceutical companies did clinical trials, that they didn't do trials in nursing homes. It would have better informed us for what was to come. We could have prepared better. It would have been a great opportunity. And I think we need to keep pushing on that. There's no question that the opportunity to reduce disease in staff is critical. We have been seeing as of late that we are continuing to have some outbreaks in nursing homes that have been vaccinated. The data shows that this primarily comes from the staff. Fortunately, even in those cases, the impact of the virus is dramatically reduced. Far fewer symptomatic cases, far fewer severe cases, far fewer deaths. So the vaccine is a game changer, makes a huge difference. Getting residents vaccinated is absolutely critical. And then finally, we're definitely going to need booster shots at some point. I think the data will be literally lagging 3 to 4 months behind the data from the original clinical trials, with the caveat yet again, whether that data tracks with nursing home residents because their immune systems are different, we're going to find out, which is why we need to continue to be vigilant. Next slide. Okay, so I want to focus on the Coronavirus Commission on Safety and Quality in Nursing Homes recommendations, because they really provide a framework for what we have to do in the future. And I think that's critical to what we're discussing here today. Okay, next slide. We've talked about testing. In a lot of ways, we needed an Operation Warp Speed for everything from PPE to testing to vaccine to getting people to be willing to be vaccinated. And I would still say that our testing capabilities leave a lot to be desired. PCR testing should be at the very least a 24-hour turnaround time. Point of care testing needs to be much simpler and easier. And I think we need to keep working on this, not only for the virus and its variants, but future viruses. This is something that really could have made a difference early on and will continue to make a difference as we go forward. Next slide. PPE, as I've mentioned, I think we've learned clearly that this virus is passed through the air, and N95s are the best for preventing that. And there should not be any supply chain issues. We're gonna have to figure out how to make this happen, but making sure nursing homes and assisted living facilities and group homes have an abundance of PPE is absolutely critical. Next slide. Cohorting, yeah, I mean, I think we continue to learn. And again, I think this is where the evidence and the experience is going to continue to guide us, and we need to listen to experts on how to effectively do this. I will make a comment that we are, with the vaccine in place now, we are now seeing the impact of social isolation, which we've seen as well throughout this pandemic. And we cannot take the lazy approach of just isolating nursing home residents. We really must look at their quality of life and figure out the most science-based but also humane ways of caring for our most vulnerable. Next slide. And that goes to the visitation. The vaccinations have been a game changer. You know, the CDC has said that people who are vaccinated can you know, mingle with people, other people who are vaccinated. And the question I posed immediately is, well, aren't nursing home residents people? And what are we doing to give nursing home residents the same right, the same opportunity that vaccination is giving everyone else? Next slide. Communications is really something I think, look, we're going to have a lot to unpack in the coming months. We've seen the good and the bad of the government and how things work and don't work. And I think communication is critical, from health literacy to interagency communications, to communication with local and county and state health departments and all those things. And I'll talk a little bit later also about the quality improvement organizations. Next slide. Workforce, this goes without saying. The data was there before the pandemic. The data is there since the pandemic. We need adequate staffing of nurses and other clinical staff and other healthcare staff to care for residents of nursing homes. One of the people put in the chat box and the questions, how are we going to pay for this? And I'll actually touch on that a little bit at the end. We're going to have to figure that out. So next slide. We need the workforce. CNAs are the most important people in the nursing home workforce. The infection preventionists have really shown their value. I'm going to talk a little more later about the role of medical directors, because today's nursing homes are yesterday's hospitals. And to not have engaged qualified medical directors doesn't make a lot of sense. Who would run their hospitals that way? We really need to overhaul the workforce ecosystem, and it is absolutely time to convene a long-term care workforce commission that's actually going to do something. And I think this commission laid the groundwork for a lot of things that really could be built on. Next slide. Technical assistance, as was noted, $250,000 have been given towards the QI and QIOs. What are we going to do with that money? And I am actually, I think it's one thing to put $250 million out there. It's another thing for that money to be used effectively. And I think we're really going to have to take a look at how we do that. We're going to have to look at how we design facilities and, how the capital is spent and such. And you're going to hear the greenhouse approach, which I think addresses a lot of these issues. Next slide. Data, we're just going to have to work on getting better data. That's the bottom line. The official data right now is there's like 138,000 nursing home deaths. When you look at excess death data, when you look at overall 80 and above death data, there's no question in my mind that that is a significant undercount. I think when you look at long-term care, which is nursing homes, assisted livings, and group homes, we are closing in most likely on 250,000 deaths. Think about that, of 1 million deaths in the long-term care continuum from this pandemic. That cannot, and I have to make one comment on that, and I've struggled with this. Nursing homes, long-term care need to be the #1 priority. We're talking 250,000 deaths in this milieu. And it's unclear that this milieu has ever been prioritized significantly during this pandemic, with the quasi exception of the vaccine rollout, where we did put it in the first tier. But even there, mistakes were made. The assisted livings were actually deprioritized. And I think we're going to see data in the coming year or two to show that in the winter surge, how many folks who lived in assisted living facilities, particularly in memory care, died. And I think the number is going to be in the tens of thousands. Next slide. Actually, keep going on this. Get past the nursing home data stuff. Next one. So, this commission actually had one dissenting opinion, and the dissent was not on all the items I talked about. The dissent was on oversight and accountability. And I want to talk briefly about that, because there's a lot of folks who will complain, hey, we did this, we had incentives, we had the QIOs working with facilities, but they didn't make the changes they needed to make. They didn't do the things, they didn't change their workflow. And I think we really need to sit down and be transparent at looking at how we're going to hold the nursing home industry, the long-term care industry accountable. Next slide. And actually with that, I briefly already mentioned leadership and management training. I always talk about the concept of the leadership team in nursing homes, which is the administrator, director of nursing, medical director, director of staff development, the infection preventionist. You need a team. We're basically running hospitals, and you just cannot have a nursing home administrator alone running things during a pandemic. Next slide. So I want to make medical direction is something that has really been known for decades to be an important aspect of nursing home quality and function. The medical director, by the federal regulations, are the leader of medical care in the facility and are responsible for the coordination of medical care in the facility. But it actually is rare for this to happen. There's data that shows the value. Next slide. So in response to that knowledge, in California, actually this bill, AB 749, just passed out of the Assembly Health Committee by a vote of 15-0 here in California to require every medical director in the state of California to have a certified medical director. And this is the first step in assuring quality, engagement, and accountability of medical directors in nursing homes. Next slide. The other side of all this has to do with Dr. Konecka. One of her slides actually showed the higher incidence of for-profit nursing homes in that lower segment of the much larger nursing homes with higher minority residency. Private equity recently was demonstrated to be associated with a 10% increase in mortality, with an 11% increase in actual taxpayer spending. Next slide. And this is the tip of the iceberg. Next slide. We actually published a paper in February looking at transparency in nursing homes to allow us to look at where the money is spent. Next slide. And that's really the key point. There's a similar bill in California for related party transparency. As we said, we've made recommendations to the administration on how to be more transparent. So I'm going to close with, in response to the question, how do we get more money? It's going to be a combined effort of making sure the money that's already there is being effectively spent, and the money we now put into the system is being effectively spent. And without transparency, that's going to be difficult to do. So thank you very much.
Thank you, Michael. Thank you for the informative presentation. And I do know that we have a number of questions that are coming in through the chat room, and we'll be answering them. If we go a little bit longer than 1 o'clock, we'll still stay on to answer questions because we know this is an important topic. As I was just watching Michael speak, there was a flash from the Chicago Tribune about the COVID study from the CDC. So again, I just think that, and it's focused on nursing homes, I just think that there is a great deal of interest. And I think it's not just from a public perspective, it's also from a humanitarian perspective. So thank you. We're now going to turn to Susan Ryan, who is going to share the Greenhouse Project and how we talked about going from evolution, now we're in a revolutionary process.
Thank
Susan?
you so, yes, thank you so much, Pat. And thank you, Drs. Konecka and Wasserman, for setting the stage so nicely. So it was a little over a year ago, early March, that I was speaking at a conference in Atlanta, Georgia. Ironically, the same time that the former president was visiting the CDC. And at the conference, there was a big buzz about COVID, and they said, so what do you think about the greenhouse model? Do you think it's going to stand the test? How will it do in COVID? And I made what was probably the most audacious statement I've ever made in my life, not knowing what we were about to go through. I said, I believe the greenhouse model was made for the moment. And a few weeks later, I went home and everything was on shutdown and the bans were happening. And I thought, oh my gosh, I hope this is true. So on the next slide, you'll see what changed for me, my career trajectory. I am a nurse, and I can tell you I was in home care, long-term care, tried to do everything to keep people out of those dreadful places. When I went to see the first greenhouse homes in Tupelo, Mississippi, it forever changed my life. It was my worlds coming together. What you see is licensed as a skilled nursing facility. This happens to be one of 2 homes in Rochester, New York, sitting in a beautiful neighborhood of a house that you or I would want to live in. So on the next slide, it's easy to get really hung up on that beautiful architecture and the physical environment that has radically changed. But I use this slide frequently to remind us it's not just the small house movement. It's not just changing that physical structure, but it's a movement. And these next 3 words are chosen carefully: to deinstitutionalize, destigmatize, and humanize care for all people so that they live meaningful and purposeful lives. So on the next slide, we're going to break it down a little bit and talk more about what that is. Real home, that's a core value that really embraces the physical environment that so radically has changed. Size matters. And Dr. Konecka told us very well, from a research perspective, we have learned that the size of the facility really mattered. So compare, on the next slide, you'll see what we have: 10 or 12 private rooms. If you go back one, private rooms with a private shower. So you think from an infection control perspective, you think of the size small, 10 or 12 people in that home. You think about a private room with a private shower. What has that done to impact infection control? On the next slide, another thing that I think is really significant, real home means that you've got a kitchen, that dietary departments are decentralized, and each home of 10 or 12 people has its own kitchen and meals are prepared there. As a nurse, I can tell you that's great for nutrition. That's great for hydration. It's really great to be able to meet the needs of a person 24/7, not being dependent on the kitchen being able to serve them. On the next slide, I think for me, this is probably one of my most favorite things, and that is access to outside. I don't know about you, but during quarantine, just being in my house was a challenge. I needed to get out. I needed to move. Well, guess what? Our shared humanity says elders do too. And so the opportunities to have a level of gardening, of normalcy. The barbecue on the left, I think, was really, really important. I call it whole person approaches. recognizing that it's not just keeping them safe from the virus, but it really is looking at them as a whole person and what are their psychosocial needs to really help boost their immune systems, get vitamin D, keep them mobile and moving. In the next slide, this is another picture. This is the back side of the two homes, one of two homes I showed you at the beginning. But look at the backyards and how they connect. Think about the opportunity to get outside, to be able to have your meal if you wanted to have your meal outside. Contrast that with what the experience was for most people in nursing homes across the country, the standard nursing home. So on the next slide, I've talked enough about the physical environment and its virtues, but let's talk about the philosophical culture that goes in. I have a saying, it's all about relationships, deep knowing relationships. We've kind of coined a phrase at Greenhouse, relationship rich, person directed living. That care is a given, but what do we want to do to ensure each person is living a life with meaning and with purpose? On the next slide, empowered staff. This is the last of three core values: real home, meaningful life, empowered staff. This gets to workforce. And Dr. Wasserman talked a bit about leadership. We say empowerment is a function of wise leadership. It's really about, on the next slide, you'll see as well, he talked about the importance of teams and really empowering the team, especially the team of the direct care workers. They're working as a versatile worker, as a self-managed work team. Next slide will tell you something else that I believe is so important. You can't have meaningful relationships, a meaningful life without consistent staffing. How do you have a relationship when staff is roving? And so consistent staffing to support the elders in that home really helps with regards to empowerment of teams and to really know who the elders are. The next slide, versatile worker. So a universal worker or versatile worker is where the certified nursing assistants have special training. Education is a huge function of equipping someone to be empowered. But a versatile worker model says, I will do the care, I will do the cooking, I will do the cleaning, I will do the laundry. And once again, all of those departments have been decentralized. So I don't have dietary carts coming in and out or dietary workers coming in and out. I don't have laundry staff coming in and out. I don't have housekeeping staff coming in and out. What does that mean? Far fewer interactions and the opportunity to bring the virus into the home. So by having a versatile worker model, we really have cut down again on those interactions. On the next slide, we're going to talk about COVID. So were the homes made for the moment? And what did we learn about COVID-19? And I just want to say something here that would be important to know. COVID didn't cause the problem. COVID exacerbated and exposed what I call systemic flaws and an institutional model that does not work for such a time as this. So on the next slide, and I will tell you, I'm going to share the monthly data, and this will give you, this is the summary for 2020 data that we collected. We worked with a researcher at University of North Carolina, Dr. Cheryl Zimmerman, to really do an analysis of our data. She worked with us to create the methodology. We started in June when CDC and CMS were requiring nursing homes report their data. And then we were doing monthly questionnaires modeled very much after what the CDC and CMS had put together to really get the raw data. University of North Carolina did a deeper dive analysis, and you can find their research published in JAMDA if you'd like to look at what Dr. Konecka very aptly said, that location was extremely important and size of the facility was important. And so Dr. Zimmerman and her team kind of drilled down and took a look at the location and the size. But here's what we learned. On the left-hand side, when we looked at our data, we started in June, took that first big swath of data, and then monthly thereafter through December. We found per 1,000 nursing home residents, you can see 214. for greenhouse compared to 445 with our traditional counterparts. The deaths, 23 deaths per 1,000 and 87. On the next slide, we're going to look month by month. As you know, gosh, none of us knew how long this would last. This was not a sprint, but a marathon. And so you can see the numbers in blue, the CMS reported data, and in orange is the greenhouse data. And you can see through the summer of 2020, everybody did better. You can see the surge that happened as we had the confluence of flu season as well as holidays through there. On the next slide, this is greenhouse, small house deaths per 1,000. And green is actually CMS. You would think green would be greenhouse, but no, green is the traditional data and the orange is for greenhouse. So even though there were cases that occurred in greenhouse homes, and as we know, some of those cases could have been asymptomatic cases. So cases were definitely there in greenhouse homes, but I think really compelling. Many times they were able to recover and the deaths did not happen. On the next slide, this is an interesting slide that talks about skilled nursing occupancy, which has been steadily declining. This is data that has been compiled by the National Investment Center for Seniors Housing and Care. And you can see a steadily declining occupancy rate looking at 2012. You get into the year 2020, this is through June, and you see that precipitous drop in nursing home occupancy. On the next slide, we took a look at, so what did we learn? And in that same data set, we were looking, our monthly questionnaires was asking for census and occupancy, similar to the way CMS was doing theirs. And as you can see in the traditional, which is now in blue, you will say they dipped as low as 69%. In greenhouse homes, we never dipped below 86%. And for many months, we were above 90%. So I think consumers are saying they're voting with their feet, number one. I do believe that the COVID data has certainly shown us that the greenhouse model was certainly made for the moment. I think there's maybe one last slide. Yeah, this is one of my favorite nighttime shots of a greenhouse community in Longmont, Colorado. So thank you very much for your time.
Thank you, Susan, and thank you, Michael, as well as Tamara. We're now going to turn to some questions, and there's some group of questions that have come in, and anyone else can still submit questions through the chat. I'm going to focus first on Medicaid because that seems to be a hot issue. And we'll start with one of the questions is, in terms of the Medicaid usage, Medicaid being a major payer for most nursing home residents, at least in Illinois, what would it take to get better funding for nursing home residents tied to quality and adequate staffing levels?
So I'll jump in. I think as I alluded to, I think we need to make sure how the money's spent. As Dr. Konecka pointed out, and I've written about this as well, incentives to me are not the way to go. And there's a few reasons. What are we incenting? We don't, as we know, the star rating system isn't necessarily the most accurate method of looking at quality. Quality in this population is the hardest thing. And disincentives, my daughter said to me months ago, we don't take money away from poorly performing schools, or we shouldn't take money away from poorly performing schools. So I think we need to identify where the problems are. And I think we know that. And then we need to put the energy, money, transparency into it. And it's not an easily soundbiteable answer, by the way. So I think that's where I'm trying to give the broad view.
I'll just piggyback off that. I do think that I have a saying, money follows what we value. Illinois happens to be one of the lowest reimbursement rates for Medicaid. And we have two communities in the state of Illinois, one in Urbana, Illinois, and they have an assisted living greenhouse home and a skilled nursing greenhouse home. And for the most part, people are paying privately in those homes because Medicaid reimbursement is so low in Chicago. The other is a federal VA. And to Michael's point, I do believe that we've got to fund, we've got to place money. If we're talking about the workforce issues that we're talking about, we've got to put money there to ensure. And then this is the other part of the support. It's the accountability and the oversight. And Michael, you were alluding to that as well. We can't just, people know how to game the system. And I won't go down that money trail, but I will say, we've got to place money in what we value, and we've got to place it there so that we can give a living wage to those that are working there. And I say a living wage, it may be beyond the 15 minimum, because it depends on where you are and what it costs to live in that area. Support, accountability, but we've got to address, this just isn't right for our society. And what do we value? And if we value our elders and the workforce that support them, we've got to put our money there.
Okay, another Medicaid question, and this is tied to Medicaid managed care. Most of the nursing home residents are under Medicaid managed care. Where were the resources when nursing homes were struggling with PPE, test kits, staffing? Did the Medicaid managed care plans step up?
So I'll jump in on that. And apologies, I had an unexpected battery problem and got kicked off for the beginning of the last question. So sorry if I'm repeating anything. But in terms of managed care, I think the short answer is we don't quite know yet, because we really need to be able to dig into more individual level data, which hasn't been available to us yet, to really sort of compare outcomes across different kinds of residents and comorbidities and insurance plans and all things like that. The one thing I would say is that this goes back to the research that private equity, for example, this is not answering the managed care question, but there's an analogy there. Private equity, for example, there's really good evidence, and Michael pointed that out, that private equity, when they take over a nursing home, the result is lower quality of care, more deaths, right? But interestingly, there are two studies out that show that nursing homes owned by private equity did not do worse for COVID. In fact, those owned by private equity seem to have slightly better outcomes, fewer deaths, for example, even if they're in a virus hotspot. And so I think the question of resources is one that's really interesting. And even if we think about managed care as perhaps, trying too hard to minimize costs, the evidence doesn't actually always bear that out. But if we think about the sort of bad incentives associated with managed care, it's not necessarily going to be the case that we'll find that, residents that were on managed care plans did worse, right? Because I think this resource issue perhaps might be one way in which we explain the total lack of correlation between low quality and response to the pandemic. They're not the same. And so for private equity, for example, it might be that private equity companies didn't see lots of COVID deaths as being in their interest. So they came up with the resources. Or it might be that some low quality facilities actually had good connections for procurement and were managed to get some more PPE even when some high quality facilities didn't. So to me, the answer ex ante is really not obvious, although it'll be interesting to dig into those questions.
Yeah, look, actually, I think the PPE, the outcomes, nonprofit, small facilities were pummeled by the supply chain issues.
Yeah.
And to your point, it is theoretically possible that the private equity owned that had access to capital, et cetera, in the aggregate might have done a bit better. I would actually argue that they should have done much better. And one of the interesting things about the early months of the pandemic was without PPE, you lost, period.
That's right.
It was game over.
Mhm.
And so the ability to provide the PPE really mattered. So I think that's interesting. I think in the general concept with Medicaid, managed care, look, I'm a huge believer in combining Medicare and Medicaid. If Medicaid's only looking at custodial care, it's not necessarily in their interest to improve health and wellness. I look at this question more from pre-COVID. I don't think we have data on COVID, but I wouldn't be real confident based on my experience and what I've seen with Medicaid managed care companies in the long-term care space. So I'd be a little skeptical.
We have a couple more questions related to Medicaid as well, or nursing homes and Medicaid. And one is, do we have any data that can be shared, or have any studies been done on short-term stays versus long-term stays, and then rehab versus custodial care? So, and I know that the volumes were down with short-term stay because patients and families couldn't visit a nursing home to do a site visit, and just, nursing home and hospital admissions were down for elective procedures and that. So any thoughts on if there's been any study on that?
Well, I think, to me, this comes back to data again. And all of those studies that we looked at, except for one or two small studies that were basically in one facility, all of the literature that we have so far, all the evidence we have so far is based on facility level data, right? So even in our race work, we had to look at the distribution of residents by race. We couldn't look at individual race because the data haven't been there yet. And so, I think as the data become more available, we'll see more and more of those studies where we can tease out, different resident attributes, including what kind of stay they were there for, what their insurance status was, and their, demographics and comorbidities as well. But I think a lot of that is yet to come. There have been facility level studies that have looked at Medicaid, including our own. And, basically the effect turned out to be pretty small once you, or non-existent, non-significant usually, once you controlled for the prevalence of the virus and the size of the facility. So it's correlated with all of those things, but that's not the driving factor in COVID outcomes. It's obviously a bigger problem for quality in general.
Okay, and there was another question too, and this is in regards to the greenhouse studies that were done. Was there any control put in place for the infection rates in the community? Was there any analysis, as Michael and Dr. Tamara, mentioned, that the effect of the community levels of virus were important?
And that's kind of the purpose of the deeper dive study that UNC did, was really to take a look at nursing home. They looked at the greenhouse in a certain geographical location, compared it to nursing homes less than 50 beds and nursing homes greater than 50 beds in the same geographical location, to really see exactly when there was community outbreak, how did it impact the larger facilities, the facilities of less than 50 beds, and the greenhouse. And in each case, it was significantly better, fewer cases, and certainly lower mortality rates.
Okay, and a question came in, can the greenhouse homes be incorporated in a continuing care community program?
Absolutely. I would say the majority of them are. We're 90% licensed as skilled nursing, and probably a good 60% of that are on CCRCs or life plan communities. The other is assisted living.
Okay. And then another question, and this is regarding the Biden tax credit. And for those that aren't aware, that President Biden announced just a couple of days ago that for not nursing homes, but for small and medium-sized businesses that allow their employees to take off to get a vaccination, and if need be, to take off the following 2 days for recovery, that they would get a tax credit. And just want to see if that's going to have any impact on increasing the vaccination rates of nursing homes, because they are lower than many would like. And also, what are some of the incentives that nursing homes are offering to help their residents and more so their staff?
I'll start with a real quick incentive that one of our greenhouse partners, there are 41 homes that he operates under his organizational umbrella. And he felt that it was so important that his workforce be vaccinated. He offered to all of the CNAs a $500 incentive if they got the vaccination during the clinics that were coming on site. He had a 92% vaccination rate of his workforce. So for him, he felt he had to put his money where he believed the safety would be of utmost importance. And he just thought it was that valuable. And, you know, to those that are living on limited means anyway, it was just a small token. And he thought it will reap the benefit incredibly so by doing that.
And you mentioned something about the minimum, living on minimum wage. And that's something that many people forget, is that the nursing home aides are working minimum wage, and they oftentimes have very little vacation. And certainly to take off, or if they get sick from the vaccine and take off a couple of days, that's a huge impact on their pay. So again, I think it's a great incentive. $500 is great. Tax credit for the employers, but are there other incentives that are also being offered? On site?
I would just jump in and say, you know, I think there are some, as good as that sounds, I think there are some somewhat tricky ethical questions here. Because these vaccines are still offered under an emergency use authorization, right? And so, like, not all the safety data is in, even though I think we're all fairly confident that they're much safer than, you know, certainly risking getting COVID, and that, you know, we definitely want widespread use of them. But sort of mandating something that's under an emergency use authorization, I think has some tricky ethical aspects to it. And, you know, I think that offering a sizable bonus to somebody who doesn't make very much money, even though it sounds like a great thing, could also involve the same kinds of ethical questions, right? A kind of coercion. And so I think, you know, I'm not sure what the right answer is, and I'm not an ethicist. I just think that those are questions that people need to think through. You know, I have heard of other kinds of incentives, like, you know, requiring much more PPE use for people who aren't vaccinated than for staff members who are. You know, certainly I think just making the logistics as easy as possible. You know, I think, you know, offering a day off or offering time off, but, you know, also just making it easy, like not putting the burden on the staff member to go, you know, find a vaccine and sign up for it and do all of that could help increase these rates of take up.
And I'll also add in, we have to be playing the long game too, in terms of, you know, the words I've been using that others have taught me. we have to respect, honor, and value that frontline staff for the work they do. And coercing them to take the vaccine by giving them a bonus versus improving their working conditions, improving their salaries, respecting the work they do, that's a very different thing. If we'd done that to begin with, we probably wouldn't be having this issue. If we do it going forward, we won't have this issue in the future. So once again, you know, it sort of goes back to sort of taking the lazy way out. Well, let's just force them to do it and then we can move on, rather than respecting these incredible human beings who have put their lives on the line for the last 13 months. I still, even as I say it, you know, I struggle as a clinician. I want them vaccinated, but as the words come out of my mouth, I know that it doesn't feel right to force them to get the vaccine. We have to educate them, work with them, respect them, do the hard work that needs to be done.
Do you believe there should be transparency in the percent of residents and staff that are vaccinated, so families and patients can make decisions?
Absolutely, and you know, that's a softball question for me, because we literally just put out recommendations from a group of experts that we sent off to CMS and CDC, saying facilities need to be tracking and reporting on their staff and resident vaccination rates. Honestly, that's a public health issue. The vaccine is a game changer. You want to know that the majority of staff and residents are vaccinated if you're moving into a nursing home or sending your loved one there. And honestly, I think as a staff member, I'd want to know in a place I'm working that, you know, that's the environment I'm working in.
And researchers need to know, right? Like, we need to be able to part this vaccination campaign and find out what worked and what didn't work. And to do that, we need to know not only vaccination rates, but, you know, when people were vaccinated, right? And all of that data should be available to the public and to researchers.
And just to piggyback on that, we're continuing to collect our data on COVID rates, and we want to also know and talk to us about vaccination rates with elders, the percentage of elders and the percentage of staff that have gotten vaccinated, so we can see the impact of the vaccine on the population as well.
Thank you. And one last question, and this, since somebody brought up, you know, to see the effectiveness of the campaign and that vaccines work. Word is out, you know, Pfizer put out the communication a couple of times now, and certainly again yesterday, that a booster will be needed. So how is that going to roll out in nursing homes, or what would be your wish as to how the booster would roll out in nursing homes?
So this, I think, again, the simplest solution is this should run through all of the long-term care pharmacies. It's the simplest distribution chain for that to happen. Again, we're just got to keep a close eye on the data coming out from the original trials. At the same time, this is why we're going to continue testing and continue looking, is if we see an uptick in cases in nursing homes, that could be an early warning that you know, immunity is waning. So to Dr. Konecka's point, data is king here. This is one of the reasons we need all sorts of data, especially related to the vaccine. So we'll be able to evaluate that data in real time, not 2 years from now, but literally as we're going forward to be able to make these decisions. If I had to guess, I'm hoping that the vaccine will be necessary approximately once a year, but that's a gut feeling based on what we've seen so far. It could be as early as 9 months. It could be 15 months. It could even be longer, depending on how long these vaccines work. But looking at a lot of the data and the studies coming out, I think a yearly vaccine is probably going to be the most likely.
I would just add, and I think everyone has kind of alluded to it, how important education is to really helping our workforce, our elders, our families, everybody to understand the why behind it. I think there's a lot of question, skepticism. I think, you know, the politicization of the vaccine and how it was made, how quickly it was made, that has fueled fear among workforce. And now to say they need a booster, it's like, okay, well, what are you saying? The vaccine's not effective. So I think education is empowering. And I think the more transparent we can be, and that's why data is so important. What are we learning? And again, leadership models the way. And they roll up their sleeves first and they really demonstrate, you know, look, I'm doing it. This is important for all of us.
Any last words from our presenters today? Because we are at the hour, past the hour. Susan, anything you want to say?
Well, I guess I would just challenge all of us to not let this issue die, no pun intended, but it's obviously I'm very passionate about it. I think the time is now for change. We can't ever go back to normal. And I think, you know, this isn't our last pandemic. There's still so much we don't know. And I think, you know, we've got to be vigilant, but I think we've also got to really advocate for what we want to see. And I think it does start with addressing our funding mechanisms and so forth, so that we can really create what we think will be helpful in the future.
And you know, I'll just say I've been in this field for over 3 decades. And I've never seen nursing homes on the front page of newspapers, on national TV. We're at an inflection point. I've not seen this amount of interest from federal and state legislators. But if we don't keep our foot on the accelerator and keep talking about it, keep interacting with our legislators, policymakers, and the media in a positive way, the industry avoids the media and they shouldn't. It's a whole other issue and story. But we need to just continue this dialogue and not let it fade away. We owe that to the nearly 250,000 who've died.
And I'll echo those same sentiments by saying, you know, this is a moment in time that may be an opportunity. And I think we should take that opportunity, you know, to really think about fundamental change, right? To stop, you know, we can keep focusing on some of the incremental things, on improving infection control, or, you know, and a minimum wage for people who work in nursing homes. But, you know, really, we need to be moving toward fundamental payment reform and figuring out, you know, big structural ways in which we can change the way we reward the workforce and improve the quality of nursing home care. This is not a time to be incremental.
So not evolutionary, but revolutionary.
Yeah.
That's where we're heading.
If not now, then when?
That's right.
I agree. I want to thank you all again for just the wonderful insight, the inspiration that you have provided for us to do better. And we know we can do better. And thank you so much. This recording will be available on the IOMC.org website. And I want to thank the attendees that are online, as well as those that are offline that have been watching this presentation. Thank you all so very much. And again, I've got a feeling we've got to do something again once the initiatives start rolling out. We need to have another conversation and continuing the conversation as well. Because as you said, don't take the foot off the pedal. We've got to keep pushing. Thank you. And thank you, everyone. Have a wonderful weekend.